My name is Ajay Nooka. I'm a professor in the Department of Hematology and Oncology at the Emory University Winship Cancer Institute. The year in review, I'll be discussing the chimeric antigen receptor therapy, the bispecific antibodies, and other novel approaches in multiple myeloma. First, I'll discuss the MRD-based study, the early and sustained undetectable MRD after receiving ide-cel, and patients defined a subset of myeloma patients in the CARMA that achieved prolonged survival. This abstract was presented by Bruno Paiva. So the background for this abstract is we all understand that MRD is prognostic for multiple myeloma. However, the MRD is a bone marrow-based technique. So there is a discordance between the responses that are seen in the bone marrow versus the serological responses. So the MRD post-treatments like CAR-T may not be the best surrogates is the biggest or the serological response is the best surrogates for the real optimal assessment of responses. So that with that background, there were questions that were asked whether the marrow-based MRD testing is optimal. If it is optimal, which is the best test, whether it's a next generation sequencing or next generation flow, and if any of these are prognostic or optimal, what is the optimal timing of this MRD testing to give us the best prognostic impact of the long-term outcomes? So Paiva's group evaluated the prognostic value of the depth of serological responses and the MRD responses among these patients receiving CAR T cells, specifically ide-cel from the KarMMa-2 trial. So MRD at the threshold of 10 to the power of minus 6 by both techniques were analyzed at month 1, 3, 6, and 12 after ide-cel infusion. As you're aware, 156 patients were screened for the trial, 128 patients received the CAR-T treatment, and among these 128 patients, MRD testing was done at least on one time point for 125 patients. The results were astonishing. There was significant concordance between NGF and NGS at each of these time points that were tested, 1, 3, 6, and 12, at the values at 67%, 75%, 82%, and 73% respectively. This may not seem like a lot, but if you look at the discordant samples, those are all related to either a hemodilute sample or an undetectable sample by the NGS. So the CR responses at 1 month are 11% with NGS with next generation flow. At month 3, they escalated to 23%, and at month 6, they were 26%, at month 12, at 13%. So these numbers were significantly higher at the MRD depths at 10 to the power of minus 6 and 10 to the power of minus 5. Going back to the question that we had, MRD negativity in the bone marrow biopsy were seen at 41% at month 1, increased to 45% at month 3. At month 6, they were 35%, and month 12 at 18% at threshold of 10 to the power of minus 6. So what do this really mean? So patients who are MRD positive at 10 to the power of minus 6, in 8 of the patients that were tested, had a negative prognostic impact. They had decreased progression-free survival. So specifically looking at month 1, so whether the patients got a CR or less than a CR serologically, the median PFS did not matter. They had 8 months versus 11 months. These are not statistically significant. But if you look on the other way, patients who are MRD positive at 10 to the power of minus 6 at month 1 had a median PFS of 2 months versus those patients who had MRD negativity, their PFS was 11.5 months. So as we went on with further months at 3, 6, 12, so those patients that had MRD negative and those achieved that greater than a CR had the longest progression-free survival reported. So there was another piece of information that was shown by Pava's group about the reappearance of normal cells. So the normal plasma cells, if they're reappearing post-CAR T, suggesting a loss of the CAR T cell persistence or the CAR T cell functionality, and could this be used as a biomarker for us to see who are the patients that would be achieving long-term benefits or not achieving those long-term benefits. So they were able to show that the reappearance of normal plasma cells suggested inferior PFS, and the appearance of normal plasma cells even among patients who are MRD negativity were able to show that inferior PFS. So now the absence of normal plasma cells and MRD negative group are the ones that had the best progression-free survival. So to conclude, the NGS and the NGF have higher degrees of concordance. The MRD positivity at 1 month is an early prognostic marker for PFS, not a serological response. And those patients who have achieved greater than a CR and MRD negativity at 10 to the power of -6 at 12 months are prognostic for improved PFS. So again, the reappearance of normal plasma cells could suggest a negative impact on the long-term PFS. And early and sustained MRD negative patients had improved PFS.
Just a couple of clarifying questions. The reappearance of normal plasma cells, is that just a histologic visualization in the marrow?
It's a great question. It is a flow-based normal plasma cells.
Okay.
So it is a next generation flow-based normal plasma cells when they're reappearing.
And I mean, it makes a lot of sense. And I don't know, maybe it's been reported a lot and I just missed it. But is this something that's been looked at a lot, the reappearance? And I mean, it makes sense, but has it been reported a lot?
This is the first time that is being reported. We all
That's what I
physiologically thought, yeah, we all physiologically thought that that is not a good sign. But this is the first ever time that they're able to show the reappearance of normal plasma cells identified on the NGF is a bad prognostic marker.
Really interesting. The other thing I wanted to ask you is when you started out talking about this, I wasn't sure whether there was some kind of theoretical concern that because of the way the CAR T works, in some way it would interfere with the assay or something. Is that the case?
That's not. So the lymphodepleting therapy and the CAR T, we are able to ablate the marrow very quickly. So, but the serological responses are the ones that typically take longer because there is a half-life of the antibody that needed to be cleared from the serum. So historically, if you look at the bone marrow and assess the MRD negativity, this is not the case. So that is the main reason for this discordance of, hey, you're seeing an MRD negativity in the marrow. So could this be the real prognostic factor, or should we be looking at MRD negativity in the marrow? And what Bruno's group was able to show was achieving an MRD negativity is not a big deal, but patients who are MRD positive are the ones that had the poorest outcome. So this is the next paper, the top line results for KarMMa-3 trial showing ide-cel significantly improves PFS versus standard regimens in relapsed refractory multiple myeloma. So what's ide-cel? Ide-cel is a BCMA targeting CAR T that has an extracellular single chain variable fragment with one heavy chain, one light chain targeting a single epitope of the BCMA. So ide-cel for the treatment of relapsed refractory multiple myeloma is approved in 2021 by the US FDA for the treatment of adult patients with relapsed refractory multiple myeloma after they have received more than or equal to 4 prior lines of therapy, including a PI, IMiD, and an anti-CD38 antibody. This approval was based on the KarMMa-1 trial. So now that we have an approval, and just like how we saw the drug development in multiple myeloma, when a drug is approved in the later lines of therapy, you really want to show the efficacy in the earlier lines of therapy. And that's what KarMMa-3 trial had done. KarMMa-3 is a phase 3 global randomized multicenter trial evaluating ide-cel compared to the standard of care options in adult patients in relapsed refractory multiple myeloma after 2 prior lines of therapy and refractory to the last regimen. So the randomization was given 2-1 to receive ide-cel versus standard of care, and the standard of care could be any one of the 5 regimens, including daratumumab, pomalidomide, and dexamethasone, daratumumab, bortezomib, and dexamethasone, ixazomib, lenalidomide, dexamethasone, carfilzomib, and dexamethasone, or elotuzumab, pomalidomide, and dexamethasone. So the primary endpoint for the trial is progression-free survival, and we received a press release that KarMMa-3 met its primary endpoint, demonstrating a statistically significant improvement in the PFS favoring the ide-cel CAR T. Again, the press release clearly shows that the safety results in the trial were consistent with the well-established and predictable safety profile of ide-cel. And clinically, what the relevance of this specific study is, we're able to show for the first ever time if the CAR T has moved to earlier lines of therapy, it was able to show better outcomes compared to the standard of care options. So the next one is cilta-cel, an anti-BCMA CAR T therapy for relapsed refractory multiple myeloma. And cilta-cel, as opposed to ide-cel, is a differentiated CAR T therapy. It has two BCMA targeting single domain antibodies to confer more avidity. So this was approved by the US FDA in 2022 for the treatment of adult patients with relapsed refractory multiple myeloma who had seen more than 4 prior lines of therapy, including a PI, IMiD, and an anti-CD38 monoclonal antibody. This was based on the CARTITUDE-1 trial, which was a phase 1b/2 study. So what Dr. Martin's group was able to do was to update the results of 2 years after the last patient in, with a median follow-up of 27 to 28 months. This was reported in the Journal of Clinical Oncology. This also included the high-risk patient subgroups. And what they were able to show was more than two-thirds of the patients, 66 of the 97 patients, remained on the study. Impressive response rates, overall response rate of 98%, stringent complete response rates in 4 of the 5 people that were treated with 82.5%. The median PFS, duration of response, not reached beyond the 2-year mark. The 27-month PFS rates and the overall survival rates were 54.9% and 70.4% respectively. This is a group of patients who had seen 6 prior lines of therapy, and at 2-year mark, 70% of the patients were alive. So very impressive results for this group. So if you look at the depths of responses of the 61 patients that had the available samples of MRD at 10 to the power of -5 threshold, 91% achieved MRD negativity, and this was sustained beyond the 6-month mark. Here, the median time to response was very quick at 1.2 months. And what they were also able to show was the long-term safety profile. From a hematological safety profile, grade 3 or grade 4 thrombocytopenia occurred in 2 of the 3 patients, that's 60 patients. But this recovered to grade 2 by day 30, and 60% of the patients recovered by day 60. So similarly, neutropenia, 90% of the patients recovered by day 60, and for lymphopenia, 90% of the patients recovered by day 60. So whenever we're using lymphodepletion therapy like fludarabine and cyclophosphamide, we always have a concern for the secondary primary malignancies. So at the 2-year mark, they reported 20 secondary primary malignancies in 16 patients. 9 had hematological secondary primary malignancies, 1 with low-grade lymphoma, 6 with MDS, and 4 cases with AML, and 11 had solid tumors, which are of different kinds. So the study also shows the long-term safety. There was no further CRS beyond the 12-month mark. There was 1 case of Parkinsonism at day 914. This is close to the 3-year mark. And this is the patient that had neurotoxicity while the patient was receiving CAR T. Don't know about the attribution, whether this is related to CAR T. So how does it change the clinical practice? This is transformative. As you're able to see, these patients, based on the Mammoth trial, based on the locomotion trial, should have a lifespan of less than a year. However, this CAR T was able to show that at the 2-year mark, 70% of these patients are alive, which clearly shows the benefit of these treatments. There are other ongoing treatments in the earlier lines to show the benefit of cilta-cel in the early relapse patient population.
So, a couple things. The second primary cancer seems kind of high. What was the take on that?
So patients had received a lot of prior lines of therapy, and majority of these patients have received a prior alkylating therapy. Majority of these patients had a prior transplant. So in such case, there is a signal that was seen when patients are living longer, when the patients are receiving more treatments that potentially put them at a higher risk for therapy-related MDS and AML. You're able to see these high SPMs in this patient population. Would this surprise me? This does surprise me that the rate is high, but in reality, these patients had received a lot of prior lines of therapy.
Another question, if a patient gets an induction regimen, like RVD, then they go to transplant, and then they go to maintenance, len maintenance, is that considered one prior therapy or three?
It's considered one prior line of therapy. So that's one of the ongoing hot topics that we have at this point of time. In 2 or 3 prior lines of therapy, you may have used all the agents that are existing out there. The indication of having more than or equal to 4 prior lines of therapy, does that really serve the purpose or serve the need of the patients, is the biggest question that we have. And in my opinion, it should not be considered as early lines of therapy, even though they're considered as one line of therapy with 3 different agents that were given. These are 3 different agents given, and the indication should reflect on that.
Do you think that it makes sense to have the indication of simply PI, IMiD, and anti-CD38 refractory, period?
I agree that should be the indication because that's the patient population with the unmet need.
Okay, please continue.
So, number one, we had seen the results from the Karma 3 trial, which was reviewed in the early relapse setting. So, we also saw at the same time Cartitude 1 trial showing the benefit of cell to cell in the late relapse setting. And clearly, the avidity of the cell to cell and the higher responses make it a very promising drug. Now, what this trial was clearly showing, presented by Ainsley's group, was look at the biological correlative analysis and the clinical data from with CAR-T among lenalidomide refractory patients with multiple myeloma after 1 to 3 prior lines of therapy. This is a cohort a cohort of CAR-T 2 trial. This was presented at ASCO of 2022. So cohort A consisted of patients who are len refractory with 1 to 3 prior lines of therapy. There are 20 patients, and this group is enriched for these high-risk patients. So number one, 5 of these 20 patients had translocation 1416, and 3 of these 20 patients had deletion 17p. So this is a group that is enriched with for all these high-risk patients. So cohort A looked for the efficacy and safety along with other markers, the T cell and the cytokine analysis as well. So the patients are younger, median age is 60, median time to response was 1 month. And as anticipated from the Cartitude 1 trial, you're seeing an overall response rate of 95%. The Syrian complete response rate seen in 17 of these 20 patients with 85%. Except one patient, everybody got a VGPR, at least a VGPR. What's very impressive here is uh, the MRD negative rates at 100%. 16 of the 16 patients had an MRD negative day. So we have to look at the patient population much more closely. These are early relapse patients. That means patients with 1 to 3 prior lines of therapy. And you're seeing grade 3 or 4 cytopenias not returned to baseline in only 20% of the patients and 15% of the patients with thrombocytopenia where it did not return to baseline and 5% for the lymphopenia. Very happy from a safety profile, from a hematological profile. From a CRS perspective, 95% of these patients had CRS. Grade 3 or 4 were seen in only 10%, and the median time to onset was 7 days, similar to what we saw with cell to cell in Cartitude 1 as well. So ICANS was seen in 15% of the patients, and grade 2 was seen in only 5%. So we talked about this in the early line of therapy. So the 2 deaths from the disease progression does not surprise me because this is a very, very high risk patient population. It is difficult to maintain the duration. What is probably preventable are the 2 deaths, one from sepsis and one from COVID that occurred among the patients that were on as a part of this study. So those are almost a 10% of the patients where the death could have been prevented. So when you look at the biological correlates, so they in the early relapse patients who are len refractory, the CAR-T peak expansion happened at day 11, and the median persistence happened all the way until the 5-month mark. So if you look at the pro-inflammatory cytokines like IL-6, IFN gamma, the ILT-R alpha, and IL-10, they peaked at 1 to 2 week mark and they returned to baseline in 2 to 3 months. And these correlated with the severity of the CRS as well. So There was increased CD4 to CD8 ratio was associated with CRS and ICANS severity as well. And they did not find any association of the CD8 plus enrichment with response to the peak CAR T expansion, probably because everybody got a response. There is nothing to compare with. So now, how these results translate into clinical practice, these results support the evaluation of cell to cell as earlier lines of therapy. This cohort did really, really well despite enrichment of all the high risk patients, like we talked about, without any unexpected adverse events. And the deaths that we talked about, including the COVID death as well as the sepsis death, really emphasize the need for using infectious prophylaxis, and the duration of this infectious prophylaxis need to be very well described in any of these CAR T trials. So there are ongoing phase 3 trials, the CARTITUDE-4, comparing cell to cell to standard of care regimens, pomalidomide, bortezomib, dexamethasone, or daratumumab, pomalidomide, and dexamethasone. So the next one is the clinical activity of BMS 9869393. This is a GPRC5D targeting CAR T in patients with relapsed refractory multiple myeloma. These are results presented by Susan Ball from UAB. And these are the first results from the phase 1 multi-centered open label study. These results were in fact presented by the last author, Jesus Berdeja. So GPRC5D is an orphan receptor that's expressed on the myeloma cells, and it does not have much of an expression on the normal cells, and it really serves as a promising therapeutic target. So previously, the MCARH109 uh, is a CAR T therapy that was published in the New England Journal of Medicine, showed that it has initial safety and promising safety and efficacy results. So the interim results from the dose escalation of study, where 33 patients were enrolled, is currently presented. Patients were younger, median age of 63, 4 prior lines of therapy, half of the patients had high risk disease, and most importantly, 54% had prior BCMA directed therapy. This is very important right now in the space where we have a lot of BCMA directed therapies, where what happens in the BCMA refractory patient is an ongoing hard question. So 5 cohorts were evaluated. Their primary endpoint was to look for the maximum tolerated dose and the recommended phase 2 dosing. The cohort started with 25 million CAR T cells. The second one is 75 million CAR T cells. We had the third cohort at 150, fourth at 300 million cohort, and fifth one at 450 million cohort. There was one DLT. This was very prolonged grade 4 neutropenia. There were 2 DLTs, prolonged neutropenia. There were 2 DLTs of prolonged duration of grade 4 neutropenia and thrombocytopenia in 2 patients, and MTD has not been reached. So similar to expected, CRS was seen in 63% of the patients, majority of low grade, and mostly occurred with a higher CAR-T dosing at 300 million or above. Again, ICANS grade 1, 2 was seen in 6% of the patients. And there were unique toxicities that are specific to this target. The GPRC5D is expressed in the keratinized tissues. So you're seeing the skin toxicity in 30% of the patients, dysgeusia, which is altered taste, seen in 15% of the patients, nail changes seen in 9% of the patients. So what is very impressive is about the dosing of 300 million cells, almost 100% of the patients achieved a response. But if you look at overall response rate across all cohorts among these 19 patients that were evaluated, 90% overall response rate. So what I'm interested more is a prior BCMA exposed cohort where there were 9 patients. Of these 19 achieved an overall response rate of close to 80%, and half of those are complete response rates. Very impressive data. This is a promising drug, demonstrated a safety profile across all the dosings that were tested, and the dose escalation is ongoing. And BMS 986393 had promising efficacy even among the BCMA exposed patients. So the expansion in the Part B is underway to define the recommended phase 2 dosing.
Am I correct in saying there's also a bispecific with the same target?
That is correct. So there is a GPRC5D bispecific that is called talquetamab, And there is a second one as well.
Interesting. Please continue.
So teclistamab in relapsed refractory multiple myeloma. Teclistamab is a bispecific antibody that targets BCMA and CD3. It recently received an approval uh, for treatment in the United States based on the phase 1 to Majestic 1 trial. There were 165 patients that were that were enrolled in this trial. These are highly pretreated patients who have received more than 5 prior lines of therapy. 26% had high risk disease, and the treatment is given as a weekly subcutaneous injection. So, to start with, patients would receive a priming dose at 0.06 milligram per kilogram. There is a second priming dose given at 0.3 milligram per kilogram before the patients receive a target dose of 1.5 milligram per kilogram. And the response rates across all cohorts was with an overall response rate of 63%, and more than complete response rate was seen in close to 40% of the patients. 44 patients were found to have MRD negativity. But if you look at those patients that achieved a CR, MRD negativity at 10 to the power of minus 6 was seen in close to half of them. Very quick response, median time to response was 1.2 months. The median PFS was 11.3 months. And those patients that achieve a response have a remission of long durable response. Among those patients that achieved a response, the median duration of response was 18.4 months. So if you look at the CRS, all grade toxicity with CRS was seen in 72%. But if you look specifically at the grade 3 toxicity, there's only one patient that had grade 3 toxicity, and counted at 0.6%. Neurotoxic events, all grades were seen in 14%, but ICANS was only seen in 3% of the patients, again, all grade 1 or 2. So bispecific antibodies given weekly with teclistamab resulted in neutropenia, all grade of 70.9%, and grade 3-4 were seen in 64.2%, anemia grade 3-4 in 37%, and thrombocytopenia grade 4 in one of the 5 patients, it's 20%. So what I'd like to emphasize is the infection rates. Infection rates are significantly higher. All grade infections were seen in 3 out of the 4 patients that were treated with this drug. And grade 3-4 toxicities were seen in half of the patients. So fully understanding that teclistamab is a first-in-class BCMA-directed bispecific antibody that was approved for the treatment of triple-class exposed or refractory multiple myeloma who had seen 4 prior lines of therapy, including a PI, IMiD, and a CD38 antibody, we clearly need better infectious prophylaxis to be defined for this patient population. So given the risks of this CRS, a REMS program, a risk mitigation program, has been established for CRS and neurotoxicity monitoring, where the patients have to be hospitalized for 48 hours after receiving the first priming dose, the second priming dose, and the target dose for teclistamab. So the next one is teclistamab in combination with subcutaneous daratumumab and lenalidomide in patients with multiple myeloma. These are the results from a cohort of Majestic 2 study, which is a phase 1b multi-cohort study going on. So just like how we talked about, teclistamab is approved for treatment of relapsed refractory multiple myeloma patients who have received more than 4 prior lines of therapy. So now in this specific study, TEC is combined with DARA and LEN in a phase 1b study at a weekly dosing of TEC evaluated at 0.72 milligram per kilogram and the second dose of 1.5 milligram per kilogram in combination with DARA of 1800 milligram and LEN of 25 milligram. So a total of 32 patients received these drugs, and of these, 13 received at 0.72 milligram per kilogram and 19 received at 1.5 milligram per kilogram. Median age of the patients was 62. They're young. These are early relapse patients. Prior lines of therapy were 2, and a third of the patients were anti-CD38 antibody exposed. Here, the most frequent adverse events were the CRS, seen in 80%. All of these are grade 1 or 2. These all resolved. There's no ICANS that was seen. Similar to what we had seen with the prior teclistamab experience, you see a lot of hematological toxicity, neutropenia, anemia, thrombocytopenia. Neutropenia was seen at grade 3 or 4 in 68%. Febrile neutropenia was seen in 12%. Uh, Again, from an infectious perspective, the same thing that we saw with teclistamab, infection occurred in 75% of the patients. Here, grade 3 or 4 infections seen in 28%. So there is one patient that died due to COVID. And when you look at the overall response rate, 13 of the 13 valuable patients at 0.72 milligram per kilogram, and 13 of the 16 evaluable patients at 1.5 milligram per kilogram, all of these had responses. So there was good biological correlative data with tagdarlan treatment leading to the enhancement of these pro-inflammatory cytokines uh, and the T cell activation. So clearly, the tech combinations have shown that the rates of infection are much, much higher. There is a clear possibility for us to evaluate alternate dosing strategy or alternate schedule strategy to minimize these risks of infections. The next one is Anita D'Souza's paper on the ABBV383. This is another BCMA-directed bispecific antibody, and clearly the study is evaluating the safety and outcomes of the phase 1 dose escalation and dose expansion study. So contrary to what we heard about teclistamab given on a weekly basis, in this study, the drug ABBV383 was given once every 3 weeks. There is no step-up dosing, and this is a 3+3 design. So a total of 124 patients, 73 in the escalation phase and 51 in the expansion phase have received ABBV 383. So what you see compared to the other BCMA directed treatment that was approved, teclistamab, you're able to see these neutropenias, anemias, and fatigue to be all grades to be much lower. So this is half as much as you expect. And it also impacted the overall response rate at 10% lesser than what you would expect. Here, the overall response rate is 57%, VGPR rates were 43%. And this to me is clearly saying as a lesser dose with a better dosing schedule given every 3 weeks is able to deliver us the benefits without causing a lot of hematological toxicity. So at 60 milligrams in the 49 patients, you're able to see that the responses to be VGPR rates of 59% and the VGPR rates of 39% and the overall response rates of 59%. In the 60 milligram expansion phase in the 49 patients, the overall response rate was 59% and greater than VGPR rate was 39%. Among those patients that received more than 40 milligrams, that means 40 milligrams or 60 milligrams in a total of 79 patients, the overall response rate was 68% and the VGPR rates were 54%. These were similar to the teclistamab dosings. Pete Voorhees presented the same exact compound, ABBV383, in this cohort of patients who had 40 milligram escalation and 60 milligram escalation and expansion at ASH of 2022. Again, as I alluded to before, the drug was administered every 3 weeks IV, and you're able to see overall response rates at 40 milligrams in 83% of the patients, with greater than CR rates in 67%, greater than VGPR rates in 83%. These rates at 60 milligrams were 60% overall response rate and greater than CR seen in 29% and greater than VGPR seen in 43%. So the 40 milligram expansion with an N of 42 was presented at ASH of 2022. The third one, which is alnuctamab, which is another BCMA targeting bispecific antibody. This is BMS 986349, which used to be given IV. So alnuctamab used to be given IV in the past, and unfortunately was associated with very high rates of CRS. Any grade CRS was seen in 89%, even though the grade 3 or above were seen in 5%. This led them to explore a subcutaneous formulation. This subcutaneous formulation was the one that was presented at ASH of 2022. Subcu alnuctamab was given on days 1, 4, 8, 15, and 22 of cycle 1, Q weekly in cycle 2 and cycle 3, Q2 weekly in cycles 4 to 6, and beyond cycle 7, patients would receive it Q4 weeks. So two step-up doses, 3 milligrams on cycle 1, day 1, and 6 milligram on cycle 1, day 4. And beyond cycle 1, day 8, there is a 10 milligram target dose or higher were explored. So overall, there are 47 patients that received subcutaneous alnuctamab. Overall response rate was 51% across all dosing regimens and 77% in patients that received a target dose of greater than 30 milligrams. So similar to the others that we had seen, any grade toxicities with the CRS were 53%. There were no grade 3 or 4 toxicities that were seen with the CRS. And neutropenia grade 3 or 4 was seen in 30%, and anemia grade 3 or 4 was seen in 17% of the patients. So with this specific compound, the subcutaneous administration definitely widened the therapeutic index and improved the safety profile compared with the IV formulation. And CRS was all limited to grade 1 or 2 events. Even though with the IV formulation, grade 3 events were seen in 5% of the patients, here the number was a 0. So high numbers of MRD response rates. Again, this is another BCMA-directed option without any much novelty when there are 2 other existing compounds there that we talked about. But what we had seen from the long-term data from the ongoing cohort suggested that there's a prolonged PFS. This is close to 36 months, the highest reported for any BCMA. There were no unexpected toxicities that were seen, including ICANS. So if you're trying to choose which is the best one existing out there, we still don't have an answer, but the jury is out there. Talquetamab, a GPRC5D CD3 bispecific antibody in patients with relapsed refractory multiple myeloma. A phase 1-2 results from the Monumental-1 study was presented at ASH of 2022. This is a bispecific antibody that targets an alternate target other than BCMA. This is GPRC5D, as we alluded to before. In the phase 1-2 Monumental-1 trial, there were a total of 288 heavily pretreated patients. These patients had 5 prior lines of therapy. 60% of the patients had high-risk disease and had treatment with 2 doses. One is a weekly dose at 0.405 milligram per kilogram, subcutaneously weekly, or every other week dose at 0.8 milligram subcutaneous every other week. So response rates were 74% with weekly dosing and 73% with Q other week dosing. Similarly, there was no difference in the greater than CR rates or the VGPR rates, showing the safety or the efficacy of these 2 regimens or the 2 dosing schedules to be quite similar. So in the 51 patients of these 288 patients, which this cohort comprised a fourth of the patient population, the overall response rate seen was 10% lesser. So this was rated at 62.7%, providing an option for post-BCMA patients. The median time to response here is, again, very quick, 1.2 months. And the median PFS reported was 7.5 months with a median duration of response of 9.2 months with Q weekly dosing and 13 months with Q other week dosing. So here the grade 3-4 anemia was close to 30%, neutropenia close to 30%, and lymphopenia close to 25%. So infections occurred in 57% of the patients at 0.4 milligram per kilogram weekly dose, and the grade 3-4 toxicities were seen in only 17% and 12%. So very clearly, you're seeing a significant decrease in the higher grade infections with an alternative target than BCMA. So one toxicity that we talked about, which is unique and related to GPRC5D, was the skin and the nail toxicity and the dysgeusia, the altered taste. And these are very low grade and clearly manageable with a lot of supportive care. CRS is low and it's low grade, and it is only confined to the first dose. And if you look at all the patients, all the 288 patients that were treated, less than 5% of the patients discontinued treatment due to an adverse event. So now, what's the take-home message for this specific compound? Compared to any of the other BCMS targeting strategies, these have significantly low rates of high-grade infections, and it makes it a feasible approach for patients who are heavily refractory and heavily pretreated. So the next one is presented by Nizar Balis's group. This is an updated safety and efficacy analysis of venetoclax plus daratumumab and dexamethasone in an expansion cohort of phase 1-2 study of patients with translocation 11-14 relapsed refractory multiple myeloma. So venetoclax is a BCL2 inhibitor, and in this specific study, it's a three-part study, and the part three evaluated venetoclax with daratumumab and dexamethasone with venetoclax at two doses, 400 milligram daily or 800 milligram daily. And the third cohort is almost like a comparator cohort with daratumumab, bortezomib, dexamethasone. These are all patients with translocation 11-14, and the overall response rate seen with daratumumab with venetoclax at 400 milligram and dex, you're able to see an overall response rate of 72.7%. When the dose is increased to 800 milligrams, you're able to see that response rate at 100% compared to a similar patient population who received an approved combination of daratumumab, bortezomib, dexamethasone. You're seeing a response rate of 31%. So at ASH, the results were presented, which included 21 patients that received the 400 milligrams of ven dose, 10 patients that received the 800 milligrams of ven dose, and 24 patients that received dara, bortezomib, dexamethasone. So again, the overall response rates were 95% and 100% with the venetoclax combinations. The VGPR rates at 86% and 100%, and the 24-month PFS rate is amazing at 94% of the patients and 83% of the patients not progressing at the 2-year mark. The overall response rate for the combined venetoclax and dexamethasone and their arms was 98%. Here, the most common adverse events are not hematological. As you can see, the non-hematological side effects are insomnia, fatigue, and diarrhea. So in clinical practice, who do we offer this to? So this is a better biomarker-defined strategy. If there's a patient with translocation 11-14, this study provides a good safety established in combination with venetoclax, daratumumab, and dexamethasone. Next one is iberdomide plus dexamethasone in heavily pretreated late-line relapsed refractory multiple myeloma patients. So this was presented at Lancet Hematology. So to bring to the background, iberdomide is a novel cereblon E3 ligase modulator. We call them the cell mods, and it has 20 times more binding affinity to cereblon compared to the regular IMiDs, and it has enhanced tumoricidal and immunostimulatory effects. In the CC220 MM001 trial, patients received escalating doses of oral iberdomide all the way from 0.3 milligram to 1.6 milligram on days 1 to 21 every 28-day cycle. This is similar to how we administered the IMiDs, and oral dexamethasone at 40 milligram per week was administered as well. So of more than 400 patients that were screened, a total of 197 patients received the dosing, 90 patients in the dose escalation cohort, and 107 patients in the dose expansion cohort. The dose expansion cohort happened at the recommended phase 2 dosing of 1.6 milligram. So median age of the patients was 65. Again, these are heavily refractory patient population. Patients had more than 5 to 6 prior lines of therapy. Overall response rate was seen in 32%. To give a context, the approved agents in the same space, belantamab as well as selinexor, both had an overall response rate of 32%, median PFS of 3 months and a median duration of 7 months. Safety, so mostly similar to what you see with the IMiDs, these are hematological, and infections remain a common theme as well. So these are well tolerable oral agents and more likely to be used in combinations than single agents, as the mechanism of cell mods is highly different than what you see with the other anti-myeloma agents. And as long as we don't have overlapping toxicities, these could serve as good additive agents or synergistic agents. The next one is by Paul Richardson's group. This is mezigdomide. This is a next generation cell mod. So here, this is CC92480. This is a potent novel cereblon E3 ligase modulator combined with DEX in patients with relapsed refractory multiple myeloma. So mezigdomide, similar to iberdomide as we talked about, has much more affinity to cereblon and degrades the icros and ilos, the transcription factors, much more efficiently, leading to the myeloma cell kill. So in the phase 1-2 trial, evaluating mezigdomide alone or in combination with DEX, uh, the recommended phase 2 dosing of Mezi was at 1 milligram daily, similar to the dosing schedule of the IMiDs or the iberdomide at days 1 to 21 every 28 days. A total of 101 patients were evaluated at Mezi and DEX. Median age is 67. Third of the patients had high risk cytogenetics, and the median prior lines of therapy are 6. Overall response rate here is 39.6%, and median PFS was 4.6 months. Median duration of response was 8.3 months. So again, these are options for combinations again as well. And given that we have a lot of bispecific antibodies targeting BCMA, CAR Ts targeting BCMA, and alternate targets, the AE profile is likely to be safe with the combinations. And having an oral administration makes it much more convenient for both of these cell mods. The hematological toxicities and the neutropenias are seen in this patient population. But if you look at the way of drug development in myeloma, if you move them to earlier lines of therapy, probably the patients have much more of a marrow reserve, and we may not see the same kind of a cytopenias in those patient populations. So again, in the clinical space, where would I fit them? Good option is post CAR T as maintenance as well as they move forward to earlier lines of therapy. So one other thing that was clearly evident here is all the bispecific agents targeting BCMA, if you look at the subsets of patients who do not respond, the extramedullary disease patients are the ones that have the least kind of a response. And in this specific study, you're able to see the extramedullary disease patients had a response rate of 31%. So the combination of an agent like this to a bispecific antibody would probably enhance those rates significantly and potentially could be used in these combinations in the future.
That was great. Wow, it's really a lot of great new stuff. Just one final question. I want to ask you right now, if you have a patient that you know right up, a couple, two things. This came up, we did a symposium last week. Sagar was part of it at ASH, and somebody said something, and I didn't pursue it, but I wasn't clear what they were saying. The idea that translocations are driver, you don't see more than one translocation, is that right?
So the likelihood of having more translocations at the same time is very, very minimal. But do we see patients with translocation 414 and deletion 17s? Yes, we see those abnormalities together, but you don't see the translocation of 414 and 1114 happening at the same time.
So if you see, because we had a case where that was seen, is that usually a lab error or something, or?
Not necessarily. These patients could have multiple translocation, but it's not the most common theme that you see. These are early events, not acquired events.
Okay. The other question I had is just out of curiosity, if you have a patient who comes in today and you know up front they have T1114 translocation, in what line of therapy are you likely to use venetoclax and with which regimen, both on protocol and off protocol?
So, as an institution, we're very biased because we are basic scientists that really help to define the treatment among these patients. So, my typical practice is if they have early relapse disease, even after the first line of treatment, if they have translocation 1114, I tend to use a venetoclax based regimen. So data
And
is
which one?
more, yeah, venetoclax and dexamethasone as a combination certainly will be my first choice. But there is more and more data that is coming in with venetoclax and dexamethasone in combination with a PI, and venetoclax and dexamethasone in combination with daratumumab, as you had seen previously. So my choice would be a PI at this point of time.
Really, the reason I ask is because I thought that daratumumab idea was pretty cool and the data looked good, but you don't think it's enough data yet to use that?
So the biggest challenge that I have when I'm using a regimen like this is I'm always looking for the next line of regimen, trying to look for what is the best combo for data. So if I'm using pomalidomide and daratumab as a next line of treatment, I always have a backup plan.